Hi, my name is Dr. Marco Raftopoulos. I'm an ENT surgeon specialising in general, adult and paediatric ENT. I have a particular interest in looking after patients who have got chronic sinus disease or any kind of rhinological condition. We're thinking about allergic rhinitis and chronic sinusitis. These are two really common conditions that we see in Sydney. It's anywhere up to 15% of the population have these. They are both very common, but they really do represent two very distinct clinical entities. And they're driven by two very different pathophysiological processes. Your allergic rhinitis, that is essentially a type 1 hypersensitivity reaction. So essentially you have an allergic reaction in the environment, typically like dusts or pollens or something like that. Contrary to that, you have chronic sinusitis. And chronic sinusitis is an inflammatory condition, often driven by an eosinophilic process, or even more recently we've discovered like a type 2 inflammatory process. The best way to think about chronic sinusitis is like asthma, but in the nose, because it's the same pathophysiology that drives asthma and dermatitis that drives most chronic sinusitis. So when we think about these two entities, one is an allergic response and the other one is an inflammatory response, they will present quite differently in the patients, and it correlates clinically with what they present with. So your allergic patient, they have got, from a nasal point of view, nasal obstruction and congestion, but they also have associated allergic symptoms: itchy eye, runny nose, sneezing, scratchy throat. That is your allergic patient. On the other side, you have your chronic sinusitis patient, and by definition, this is symptoms lasting more than 12 weeks, and they have got terrible nasal discharge, lots of congestion in their nose, they have loss of smell, they occasionally have facial pain and fullness, and it's this group where they have polyp disease and polyp changes inside the nose. From a clinical exam point of view, essentially what you are looking for are two distinct things: features of hay fever and allergy, or features of chronic inflammation. When we examine these patients, especially in children, they'll have a blocked nose, a runny nose, anterior clear rhinorrhea, but they may also have allergic creases under their eyes, allergic creases over their nose, and associated sneezing as well. Your chronic sinusitis patient, they're going to have less of those allergic-like symptoms, but rather they might have an incredibly blocked nose that, if you look inside, may indeed have polyps as well, and they'll have a yellowy or green discharge that's really quite persistent out of their nose. Obviously, part of the workup in terms of differentiating between these two is a investigation process, and each of them are designed quite separately to isolate whether we're dealing with an allergic process or a chronic inflammatory process. So just concentrate on the allergic one for the time being. A set of blood tests and imaging investigations are important. In addition to that, there's added tests as well. So the blood tests that are useful for us, and it does actually cross-correlate with the chronic inflammatory one as well, but really I need a RAS test, which is a radioabsorbent test, and what that does is it tries to isolate the specific allergen that is causing the allergic rhinitis. The second test that's very important is an IgE, and what that really is a test to determine how allergic somebody is rather than what allergen specifically. And the third test, which is useful, which cross-correlates with the chronic sinusitis, is a full blood count looking specifically for eosinophilia. And the eosinophilia tells me, is this the type of patient that actually has got an eosinophilic disease that's driving this process? Less so in the allergic patient. The additional useful test that we can use, if it's available to you, is a skin prick test, because that is a highly sensitive test which gives us a lot of information as to the degree of sensitivity people have to allergens in the environment. So that's enough from a blood test point of view and additional test. In addition to that, imaging. I always find it useful to have a CT scan of the paranasal sinuses with bone views concentrated on, as this gives us a sense of the location of the congestion in the nose and really does help us determine, is this a patient who's got chronic sinusitis or allergic rhinitis, because occasionally it can be difficult to differentiate between the two. Crossing over to chronic sinusitis, it's actually a very similar set of initial investigations. Again, blood tests, including a full blood count, specifically for the eosinophilia. And yes, it's useful as well to have a RAS test and an IgE because it helps to know if there is a degree of allergy, although that's less important. Really, it's the imaging that's going to help us the most, and that's the CT of the paranasal sinuses. The CT is useful to me for two main reasons. One, it acts as a roadmap from an operative point of view. It shows me in detail the bony anatomy, which is essentially what I need to have in front of me to be able to make sure that if there is a procedure or an operation planned, it can be done as safely as possible. It identifies the anatomical structures that we look out for as surgeons to ensure that the procedure is done safely. The second crucial element of the CT scan paranasal sinuses, it tells me about the extent and nature of the disease. Chronic sinusitis incorporates a really large umbrella of terms, and it's the features on the CT scan which help us subcategorize the type of sinusitis that they have and the subtype of chronic sinusitis that they have. So when a patient does come to us with an up-to-date CT scan and those additional blood tests, it's incredibly useful in us being able to formulate a management strategy. So with regards to the management strategies that we'd be using for these patients, we'll just concentrate firstly on allergic rhinitis. The philosophy around treating allergic rhinitis is what we would call a ladder approach. And the first step is reducing environmental exposure to an allergen. So once we've established there's an allergen in place, we can ask our patients to change or modify things in their environment that's going to help reduce the burden of that allergen. So changing from curtains to blinds, trying to remove carpets from the household. This is more specific for, say, house dust mite, but there are things that people can avoid. So allergy avoidance strategy is the first step. The second step is being able to help clean or wash the allergen away. So we would often recommend a trial of a nasal rinse specifically, rather than a spray, but a rinse, a high volume rinse. And what that does is it allows some of those allergen stimulants to physically be washed away. The next step up is going to be two elements. One, to reduce the inflammatory process in the nose, and secondly, address the effect of the hypersensitivity reaction. So a spray should be utilized following a rinse in the nose. Commonly, intranasal corticosteroids are used, such as mometasone spray, and that's branded as Nasonex. But in addition to that, there are other ones on the market which contain both a intranasal corticosteroid and an antihistamine. These are really effective first-line sprays to help control those nasal symptoms. The use of those sprays is really important. What we always recommend to patients is that they trial a rinse and a spray for at least 4 weeks. And what that constitutes is, especially in the evening or whenever it's easy for the patient, to rinse their nose appropriately and then use 2 sprays in each nostril of either the intranasal corticosteroid or the intranasal corticosteroid with the antihistamine, and we give that a trial of the first month. Now, those are your initial medical steps that you can do to manage the patient. Concurrently, in patients who've got very severe disease, there are additional options available, such as immunotherapy. Now, immunotherapy is driven primarily by the immunologists, and that constitutes a low-grade exposure of the allergen to a patient for a prolonged period of time, essentially desensitizing them. That is a very effective strategy of management, but it does take quite a long time to complete treatment, often up to a 3-year treatment process. We've talked about changing the environment, initial management strategies in terms of sprays and rinses, and the idea of immunotherapy. The question then is what or where is the role of surgery? So as a surgeon, we clearly cannot cut allergy out. And that's a really important thing to discuss with patients, especially because we need to be able to manage expectations in terms of where we can help treatment. The role of surgery is designed to help alleviate the main symptom that patients come with, and that's a blocked nose. The surgery is excellent at unblocking the nose. It allows a patient to have relief from their daily congestion and their daily inability to function whilst their nose continues to remain blocked. So surgery is an adjunct in the care of the allergic rhinitis patient. The procedure that we most commonly offer for patients, in the absence of any other complicating factors, is a turbinoplasty with or without a septoplasty, to create space in the nose so that these patients can at the very least breathe really effectively, and often that's the thing that they just want fixed the most. I always tell patients afterwards that after unblocking the nose, it provides the space for them to effectively then deliver the sprays and rinses into their nose that are going to ultimately control the allergic symptoms better. So the one complements the other. Chronic sinusitis, that is a very different clinical entity, and the management of chronic sinusitis at a GP practice level involves firstly identifying that that is the clinical process at hand, and then secondly instituting initial management strategies. This group really requires excellent rinsing and excellent delivery of intranasal steroids. So the rinsing for these patients, and what I mean by that is a high flow volume rinse. They get branded as Neomed or Flowmed, but either way, it's a volume of water that's mixed with a salt solution that needs to be rinsed 2 to 3 times a day for these patients. In addition to that, an intranasal corticosteroid helps to control, to maybe some extent, some of the symptoms. In addition to that, these patients should at some point have a trial of a steroid, an oral steroid. So again, thinking about it in terms of asthma, which is essentially what this is, these patients need to have at least a trial of a strong anti-inflammatory like prednisone for a duration of time to see if they get an improvement of their symptoms. Because on occasion, these patients can be treated with periodic steroid use. Ultimately though, too much steroid use is not safe for the patient. And so when a patient is requiring too many steroids or it's not controlling their symptoms, then there is absolutely a role for referral to an ENT service to discuss other options. Occasionally, these patients also need antibiotics, so a trial of a short-term antibiotic like Augmentin or even longer-term antibiotics can be used as an initial strategy. But useful is these patients having had at least a trial of rinses, sprays, prednisone, a full CT scan before they arrive, because then we can offer them the next step, which for us is going to be comprehensive sinus surgery. Again, the goal of sinus surgery, we can't cut out allergies, we can't cut out asthma, but what we can do is we can create the space to deliver the rinses and sprays with steroid that ultimately control this disease. Interestingly enough, as we have a greater understanding of this disease, we are learning that soon there will be medications available that allow us to control this disease in the same way that asthma is becoming increasingly controlled by a biologic medication. We're noticing, and we are having evidence to show that it increased biologics in CRS or chronic rhinosinusitis is also becoming available, but this is more looking at the future. But at this stage, initial rinses, initial sprays, antibiotics and prednisone is perfect in terms of the initial management plan for these types of patients.